Okay, we are going to go ahead and get started. Dr. Browning has a lot to share, so I want to make sure he has plenty of time. And I am going to be introducing him today. Dr. Landon Browning is a Boise native who attended Boise State University, then University of Washington School of Medicine, and will be finishing residency in psychiatry in June. He has worked in a variety of settings, from clinical laboratories researching ovarian cancer to serving the community through programs that aim to improve LGBTQ plus mental health disparities in the Treasure Valley. He will be sticking around after graduation and joining the psychiatry service at St. Luke's Hospital in the outpatient setting. Dr. Browning is passionate about improving knowledge of evidence-based practice in Idaho. He is excited to discuss the historical and current ideas around bipolar disorder and hopes to incite a discussion around the concept of the bipolar spectrum.
Thanks, Deb. Thank you all for coming. So today I'm going to talk about the idea of the bipolar spectrum, what it is, where it comes from, and how it's held up. So there's a lot to get to. Let's get started. Okay, so briefly, I just want to start at the beginning, bring us up to the last 50 years. So the earliest attempts at classifying mood or personality was with Hippocrates and 4 humors, which were different fluids in the body. The choleric, sanguine, phlegmatic, and melancholic, to be specific. And then over 1,000 years later, we get Jean-Pierre Falret publishing in 1851 on Folie Circulare, which he meant by linking 2 states of extreme mood with free intervals. Then Karl Kalbaum published in 1863, classifying between Vacordia, meaning limited disturbance with remitting course, and Vasania, meaning complete disturbance with progressive declining course. Then Emil Kraepelin took those ideas and created classification of dementia praecox, which we know of as schizophrenia now, and manic depressive insanity or bipolar disorder. Now let's look at how this concept has evolved with American psychiatrists through the evolution of the DSM. So the DSM-1 in 1952 classified it as a psychotic disorder. Then in DSM-2 came out in 1968 and characterized it as an affective disorder. DSM-3 in 1980 introduced the concepts of episodes that could be manic or depressive, and it gave a specific symptom criteria and checklist. Had not done that before. The DSM-4, so there were 14 years between the 3 and the 4, came out in 1994 and specified criteria for hypomanic episode, and they added bipolar 2 disorder with hypomanic episode. And then DSM-5 in 2013 wasn't that different. So with that brief summary of the history, let's go into why I'm truly interested in this topic. And maybe of you have also had this thought, but why am I seeing so many bipolar disorder diagnoses in my outpatient practice in patients that have never had a manic episode? So is this just me? Am I missing something after all the training? So with a search on PubMed, I could see that it looks like it's a phenomenon happening around the country, and others are noticing as well. Here's a 2008 paper from the Journal of Clinical Psychiatry called Overdiagnosis of Bipolar Disorder Among Substance Use Disorder Inpatients with Mood Instability. They retrospectively looked at 85 patients previously diagnosed with bipolar disorder in a dual diagnosis mood and substance use disorder inpatient unit. Using the SCID, or structured clinical interview for DSM, 33% of the subjects met criteria for bipolar 1 or 2 disorder, and the rest did not. They add the present findings demonstrate the low diagnostic predictive value for 2 clinical features commonly assumed to be suggestive of bipolar disorder: mood instability and irritability. Then I stumbled upon this huge study done out of Brown by Mark Zimmerman in 2008. He conducted a really large study. There's way more patients than the 700, but with the goal of using the SCID and structured interview to increase diagnostic fidelity. He published a lot of papers out of this study, but I think the most interesting findings regarded bipolar disorder and folks with previous diagnoses of bipolar disorder, including this paper, is bipolar disorder overdiagnosed. So the real whole title of the MIDAS project is the Rhode Island Methods to Improve Diagnostic Assessment and Services. And out of 700 folks in one of the samples, 145 had previous diagnosis of bipolar disorder. Looking at those folks, he was curious how many would be diagnosed based off of the SCID. And then he also used this screen, if you will, the family history for research diagnostic criteria. That's kind of like a structured way to look at family history as an index of diagnostic validity. He found 43.5% of those 145 patients were actually meeting criteria for bipolar disorder. Then he adds, it is within our opinion that an overdiagnosis rate of more than 50% represents a problem. Overdiagnosing bipolar disorder can unnecessarily expose patients to serious medication side effects. In another study in 2007 called Is Bipolar Disorder Overdiagnosed Among Patients with Substance Abuse? Patients were recruited from a residential treatment facility for substance use disorders. To qualify for the study, patients had to be currently treated or have past treatment for bipolar disorder by a psychiatrist. Out of 21 patients, 42.9 of them met DSM-4 criteria for bipolar disorder using the SCID. And they conclude, in some settings, bipolar disorder may be overdiagnosed. The study demonstrates that in patients with substance abuse, or that patients with substance abuse may frequently be misdiagnosed by psychiatrists as having a bipolar mood disorder. Another paper, 2013, reviewed 7 papers that looked at overdiagnosis and said that they range from 4.8 to 67%. They had some interesting conclusions. They explained the evidence suggests that while clinicians' diagnosis has a high negative predictive value, meaning if you don't think they have it, then they probably don't, its positive predictive value is relatively low, meaning that if you think they have it, it's not very certain that they do. They discuss the confounding factors that may contribute to overdiagnosis of bipolar disorder, including personality disorders, substance use disorders, and ADHD. They say about the bipolar spectrum, as the concept of the bipolar spectrum is progressively expanded, the diagnosis of unipolar depression becomes extremely restricted and tends to disappear. Despite the controversy surrounding this concept, it has gained immense popularity over the last decades, and many clinicians adopt this model to formulate or sometimes justify their diagnosis of bipolar disorder. A dimensional diagnostic model like bipolar spectrum disorder tends to blur the boundaries between different diagnostic concepts and normalities, decreasing even more the diagnostic reliability across different providers. They also, just quickly say this, they cited from another study, 172 patients on disability due to a diagnosis of bipolar disorder. Out of the 172, only 47.6% of them actually met criteria for bipolar disorder. And those are folks on disability. So, how did we get here? In order to figure that out, we have to go back to 1981, right after the DSM-3 came out, 13 years prior to publishing the DSM-4, and we find this guy, Dr. Akiskal, a then academic psychiatrist at the University of Tennessee in Memphis. He completed a study and cites data in the study that is unpublished, his own data, of 100 patients that had a diagnosis of borderline personality disorder. And he found that nearly 2/3 of them had an affective disorder, with criteria for various bipolar disorders that he had made up. Also, he used 2 biomarkers to show strong similarity of the borderline patients to patients that have a primary depression, and says 2 recently developed biomarkers also strongly suggest the close affinity of borderline psychopathology to affective disorder. And those were a delayed escape from dexamethasone suppression and then REM sleep latency. He makes this kind of crazy leap in this paper. It's one of the first times it's really picked up in a journal that isn't his own journal. And he says the obvious answer, the obvious answer to this, the reason that borderlines have affective disorders, is that 1/5 of borderline patients have personality disorder, and 4/5 of borderline patients instead have an atypical, chronic, and complicated form of affective disorder that causes their personality disorder. In other words, there are cryptic mood disorders such as cyclothymic, bipolar 2, bipolar mixed, and dysthymic mood disorders that cause folks to have symptoms of BPD. In this paper, little chicken and egg thing. It's a very extensive paper. He provides 3 case examples in addition to the 100 unpublished patients that he uses, that he cites, kind of diagnosing with his own criteria. But he uses these 3 case examples to kind of try to illustrate his point or his theory, I guess. So the first one is for bipolar 2 disorder. Remember, this is 13 years prior to it being recognized in the DSM-4. I kind of summarized some of what I thought were the pertinent presenting symptoms in the case here. So 27-year-old woman presenting for outpatient psychiatric care with a chief complaint of boredom from existing. In all of these relationships, she was possessive and would exhibit a mixture of rage and suicidal impulsivity, demandingness and temper outbursts, feelings of self-disgust and not wanting to exist, uncontrollable crying spells, needed violent sex to feel alive. She was most often considered borderline. She had been in psychodynamically oriented therapy for a 3-year period with little change, up to 60 milligrams per day of phenelzine, low-dose neuroleptics, and tricyclic antidepressants. In his assessment, he states the patient was diagnosed as having bipolar 2 disorder and placed on lithium carbonate. After 2 years of such treatment, her existential boredom, sedative hypnotic dependence, insomnia, and irritability have been largely eliminated. Sexual problems and outbursts of anger have occurred, but less frequently. It is our clinical experience today, or our clinical experience today indicates that, as expected, this sense of poor ego control is responsive to lithium in a large number of cases, suggesting that psychodynamic speculations about developmental origin are probably irrelevant in cyclothymia. In the interest of time, I skipped the second case. It's very similar. The third case is on dysthymia and goes, 22-year-old male student has been in individual psychotherapy intermittently since his mid-teens because of confusion about his sense of direction in life that had led to repeated suicide attempts, usually by overdoses of psychotropic medication. His previous therapist described him as a borderline personality who at various times had suffered from inner emptiness, insecurity, panicky anxiety, and identity diffusion, all of which were augmented by a recent engagement to a sexually demanding woman. Alcohol and marijuana abuse, and then also, this is a little graphic, but he would express the view that he had no suicidal intentions when he cut his wrists, but to experience the delight of warm blood flowing from his body. In his assessment, he says, it was explained to the patient that the success of lithium prophylaxis depended on at least 1, and preferably 2 years of uninterrupted trial of this salt. Psychotherapy, 30 to 45-minute sessions every 4 to 6 weeks, was supportive and practical in focus. After a total of 3 years of treatment with the lithium in context of psychotherapeutic support, the patient is now free of incapacitating episodes of depression. He may experience an occasional down of 3 to 4 days, 2 or 3 times per year. Identity questions recur from time to time, but seldom bother him. The conclusion at the end of this paper that he draws from his unpublished study of 100 patients and with borderline personality disorder and 3 case examples is, it is important to recognize that an access to personality diagnosis in chronic affective disorder is often secondary to the affective disorder. And unless definitive treatment is provided for the mood disorder, the personality disorder is unlikely to respond to psychotherapeutic attention alone. As previously reported by the author and his associates, an unstable sense of self often results from cyclothymic mood swings, one that is largely refractory to psychotherapeutic intervention. Lithium carbonate and supportive approaches are usually sufficient in such cases. So 2 years later, he published The Relationship of Personality to Affective Disorder and states the assumption that personality disturbance precedes affective episodes has yet to be demonstrated. In fact, we think it's the other way. Basically, again, saying that affective disorder is the cause of personality disorder. He makes a statement, unequivocal response of patients with personality disorders to lithium carbonate and a placebo crossover design lends modest support to the contention that certain personality patterns are the expression of affective disorders. And then the periodic anger and periodic obsessional symptoms are reported to respond to lithium. So yeah, he claims that lithium is effective for personality disorders and that personality disorders, and that because of that, the fact that he makes this claim that lithium works to treat personality disorders, then personality disorders must be a variation of bipolar disorder. In 1987, 7 years prior to the DSM-4, he publishes this extensive article, Criteria for the Soft Bipolar Spectrum Treatment Implications. I didn't feel we needed to go deep into it, but I've included some of the images from the paper so you can get a sense of his reasoning. There's some diligent mood mapping and a reference to a previous study where he diagnosed the patients using his made-up criteria. He writes, as reviewed elsewhere, current evidence now favors the view that many, if not most, recurrent depressions belong to the bipolar spectrum. In his summary, he states this paper has drawn attention to a large and neglected universe of a soft bipolar spectrum characterized by abrupt biphasic shifts in mood, cognition, behavior, and circadian rhythms. Such vulnerability has important implications for the treatment of mood disorders and suggests caution and overzealous use of tricyclics, where subtle indicators of bipolarity can be demonstrated. 3 years after this paper was published in 1990, the NIMH appointed him as the senior science advisor for mood disorders. Moving on. So here we are in 92, the DSM's been published. It includes bipolar 2, and he publishes again. This paper proposed subtypes of bipolar 2 and related disorders with hypomanic episodes or cyclothymia and with hyperthymic temperament. He has a case series study of 687 primary depressives, uses his own criteria for different bipolar diagnoses to conclude the following. Patients who have major depressive and hypomanic but not full manic episodes have been recently considered to represent a form of bipolar disorder type 2 by a relatively small number of researchers. And the small number of researchers we'll kind of get into later. One of them is this guy Peruggia on this paper from the University of Pisa. Another one is a French researcher that he convinces of his ideas. Skip that. Our data indicate that major depressive episodes with a history of either short-lasting hypomanic episodes or an enduring hyperthymic temperament can both be placed within the spectrum of bipolar disorders. So clearly, his ideas were very influential in the creation of bipolar 2, putting that in the DSM-4. There's a lot of kind of behind the scenes that happened there. We don't have a lot of time for that, but it's kind of fishy. This journal, the Journal of Affective Disorders that he published this paper in, is his journal. He started it in 1979, and he is the co-editor-in-chief throughout this whole time. You'll see this journal pop up quite a bit. Now we get 1996, and he gets this paper into the Journal of Clinical Psychopharmacology, the prevalent clinical spectrum of bipolar disorders beyond DSM-4. I won't belabor it either, but wanted you to all notice the studies cited in his data. So based on Akiskal, summarized from Akiskal and Malaya, which is his 83 paper, updated from Akiskal and Associates. Yeah, keep going. There are a lot of more papers. He was very prolific, and they're all pretty similar in advocating for a vast landscape of bipolar disorders that encroach on many other psychiatric disorders. I personally think they're kind of unimpressive, anecdotal, and a little far-fetched. He publishes on atypical depression being a part of the bipolar spectrum, saying that this treatment resistance and medication side effects prove this. not a very logical argument, but I've included this paper to show how out there he kind of kept going. The Evolving Bipolar Spectrum Prototypes 1, 2, 3, and 4 says the material in this article is supported by the author's own clinical experience and the existing research data. A strong case can be made for bipolar types 1, 2, 3, and 4. And then he has 1.5, 2.5, and 3.5. So I will let you all read that at your own leisure. And kind of cites his previous work as grounds for these theories. Says ongoing international research continues to provide robust support for the broad bipolar spectrum. This concept would enlarge the territory of bipolar subtypes up to 50% of all mood disorder. So clearly there were a lot of American psychiatrists drinking the Kool-Aid. One very well-known one, Dr. Stephen Stahl, was buying it as well. Maybe some of you have heard about him. And when I was doing this topic, I was like getting flashbacks of reading his psychopharmacology when I was a fourth-year med student doing my sub-I, and coming across these super elaborate like mood graphs, and kind of just skipping over them because it just seemed kind of frivolous at the time. But now looking back, I'm like, wow, this is interesting. So I pulled out the version that we have of Stahl's now, Essential Psychopharmacology. Couldn't find them. He took them out. He took them all out. So it just kind of shows you there's been evolution of things. So number 1, bipolar 1.5, bipolar 2.5, 1/4, bipolar and a quarter, bipolar and a half, schizobipolar, cyclothymic, bipolar 3.5, some substance abuse, bipolar 5, bipolar 6, and yes, he did take them out. So things there's a pendulum here that I'll keep talking about. Yeah, so Akiskal kept publishing, very prolific, and he kind of wanted to draw connections between a lot of psychiatric disorders related to bipolar 2. So this paper, Depressive Comorbidity and Panic, Social Phobic, and Obsessive Compulsive Disorders, re-examined, is there a bipolar 2 connection? And then he says the soft bipolar spectrum redefined, focus on the cyclothymic, anxious, sensitive, impulse discontrol, and binge eating connection in bipolar 2 and related conditions. He also met with his pal Perugui in Barcelona, and another academic. He convinced the one in France, Jules Angst, to come up with the 1998 International Barcelona Consensus on Bipolarity, where bipolar 2 is hypomania for 2 or more days. There's mixed manic states. He's got some somatic treatment-induced hypomania, cyclothymic, which parenthesis borderline personality. So he really doesn't like borderline. The concept of that, and wants to frame everything in the concept of a mood disorder. It keeps coming. There's just a bunch of stuff that's being published. A lot of it actually coming from his own journal, right? Like he's authoring these papers and then publishing them in his own journal, which is kind of also fishy. Keeps coming. And he also authored a chapter on Kaplan for mood disorders. So I actually found him talking about his ideas at a University of New Mexico in a grand rounds in 2012. And I really wanted to show some clips so you can put a face to the name. So in this first clip, he's talking about how he started this idea, and he says some weird stuff about skin. So let's watch it.
I like this. It's a book in which I wrote the first chapter, and the book is edited by 3 presidents of the World Psychiatric Association, and the publisher, to sell the book, if something is very common, it will sell more books. That's the idea. Says from my chapter that it affects up to 5% of the population. That's the spectrum. There's no question about it. We're talking about 5%. That's 1 out of 20 people. So there must be some here, at least in the spectrum. At least 2. Jen and me were in the hyperthymic spectrum, he said yesterday. I'm not going to contest that. Sam is somewhere there too. All leaders are. Sorry, but this is a compliment. It's nothing wrong with it. A lot of creative people are somewhere in the normal range of the spectrum, let's say. Now, there has been virtual revolution in the bipolar field. They say it's an exponential growth in the literature. that many publications.
This
As
is
far as the
history.
bipolar spectrum, there are 526 publications in PubMed. And that is since we started this idea of a spectrum. Actually, it's the first paper I published in a refereed journal in the United States. We studied individuals in a mental health center who
1977.
was sent to me by social workers and nurses who said, well, he or she does not have manic depressive illness, which was a term in those days, but has some features. And we have done everything psychotherapeutically, nothing happens to them. So why don't you look at them? So we studied these patients and we followed them up. And this is the only paper I've ever published that was published without any change. The editor accepted it immediately. That was Dr. Braceland, was the editor at the time, just before Nehemiah. Okay. Now, a very important paper had been published earlier, many years earlier, from an IMH, which described patients who were bipolar 2 as opposed to bipolar 1. Now, you would think that this is like diabetes type 1 and type 2, but that's not how it was derived. David says that they already had a paper on bipolar disorder at the APA, or biological psychiatry, to be presented. And Goodwin said, I want these patients that were doing suicide after they left an IMH. So Donner did the paper at the last minute and called it the paper 2, you know. And so that's how they were called bipolar 2. Actually, you would think that it's a lesser disorder. Actually, bipolar 2 is a more serious disorder because bipolar 1 is clear. You know, they were misdiagnosed schizophrenia a long time ago, but diagnosis of mania is quite, you know, even the janitor and the policeman diagnose it. But bipolar is a very subtle disorder, and it's very dangerous because they are the ones who are the most suicidal. That's what the study said. Indeed, I was amazed they published this paper because it says they were attempting suicide at an IMH, and after leaving an IMH, they're doing suicide. Now, you could say that the National Institute of Mental Health, the highest public health, you know, institution in the United States, would be a little bit embarrassed, but I think they were very candid. It's a statement that we need to study this condition. Has not been studied as much as it should be, because there are many controversies about it. Now, this is bipolar 1, probably an irritable mania, irritable, aggressive, you know, dysphoric mania, something like that. It certainly is not euphoric. Very common. Typically, a psychotic illness can be confused, in the past with schizophrenia. Now, this is a different kind of disorder. Yeah, she's from Elle magazine. And this patient I can diagnose without examining her. It's not the flamboyance, which certainly helps. It's something very unscientific, I will say. The French call it sens clinique, it's a clinical sense. It's something about the quality of the skin of these individuals. A lot of bipolar 2s are in Hollywood because they have a very special kind of skin. You would say, well, they receive all the kind of treatments for their skin, but even without, see, they got there because they had a special splendor, their skin. It is something very different from the rest of women who are not in Hollywood. Well, unless they're in the bipolar 2 spectrum. No, I'm exaggerating. There's a kind of skin quality to it. If you'll permit me one unscientific statement, this is it. Okay. So I forgot, I can see it from here. It leads to differential diagnostic problems with personality disorder characterized by mood instability, obviously. They are beautiful, they get into trouble in the field of love. A lot of men are interested in them, a lot of rich men are interested in them, and they have disappointments. They may take overdoses, and they get angry, and all kinds of things happen. Some of the so-called borderline phenotype is created by the life of these individuals, I don't like the word borderline.
Says
Do you know that the
he
month
does not like the word borderline. So oof, big oof, right? Let's see. Next. There we go. So here he is a kind of shorter clip. He describes how he got one of his most important papers published, written from memory in one day, and does it in somewhat, his.
I had the podium of the APA in New York thanks to Paula Clayton, the lady of American psychiatry, if I can qualify her as that. She's really dignified, attractive intellectually as a person, and is now the director of the Suicide Society, right, Jan? I'm sure you collaborate with her. And she had invited David Thomas to this meeting, so that this talk about bipolar spectrum got great visibility. Journalists come, in New York. So I was very happy to be there and tell you, see what age does to people. But my wife thinks that I'm younger than in that photo. That's what she thinks. But anyway, that's good to have a wife who thinks that way. Okay. Now this was another visibility. This is a very special place in my life, this paper, because.
So we looked at this paper.
I'd written a great deal about soft bipolar, and was receiving a great deal of criticism. Indeed, I presented it in the NCDEU meeting. This is a meeting where they ask people to present their most provocative ideas, and they'll publish it unchanged if you give it on time to them. And I had not had the time. My mother had died, and it was a very difficult time for me, and I had not written until the last day. And I was, Nina Schooler was the editor, I think. She called me and said, Hagop, you have one more day. You don't send it tomorrow, it won't be published. And I was, in really bad shape. And mother died somewhere. I couldn't go to the funeral. It was actually the civil war in Lebanon. I couldn't go to the funeral. And it was impossible to go. Now, I wrote this paper in one day by memory mostly. And it got there by fax that evening. So that's the story. And it's one of the best papers I've written. And it's very highly cited. Gopinath Malya was, I loved Indian psychiatrists as residents. Actually, I kept him as a,
Okay.
I had the podium.
Next, so here he explains, and sorry, there's only, I think this is, there's one these are much shorter, but here he explains how a pharmaceutical company influenced him to do a large, well-cited study to increase the use of mood stabilizers in France. He makes the claim that we should not deprive patients of mood stabilizers. So I just want to show this
paper when I said something that DSM-5 would kill me if I say this, because this is the big debate. A narrow concept of bipolar disorder would deprive many patients with lifelong temperamental dysregulation and depressive episodes of the potential benefits of mood regulating agents in the absence of evidence. But as a clinician, what do? You have the right to prescribe, but a lot of people would frown upon this kind of practice. I'm not going to ask any one of you what you do, but this is what I said in the Journal of Clinical Psychopharmacology. It's in the abstract. When I was faced with this, a mother, a father was concerned, I bring them. Is it better to be treated pharmacologically or to be in long-term psychotherapy and repeated suicide attempts and things like that? I don't know. Now, you would say, don't they attempt suicide doing this? Well, I'll show you my statistics at the end of the paper. Now, the biggest chance I had in this field was in Brazil, the World Congress of Psychiatry. A French pharmaceutical company came to me, Sanofi, Sintelago, and said to me, we want to promote bipolar disorder in France. They said, we want to promote our product, they couldn't, the French version of what's the Bipolar in the United States, how we should promote it. I said, I don't know how you should promote it, but I said, for psychiatrists to prescribe it, you should promote the illness. So what are you talking about? I said, well, Upjohn did that for panic disorders. They had to introduce panic disorder into DSM so that there was a diagnosis for their product. It was really a fun thing to do. It was a congress where there was nothing about their product. It was all about panic disorder. Donald Klein introduced the concept that way. So I was telling them the same thing. We have to introduce bipolar illness in France. The French never liked the diagnosis of bipolar disorder. They call it psychose maniaco-depressive. They would only diagnose the severe cases. Because, you could say the French are very kind of cyclothymic by temperament, and for them it's normal, to be that way. And I said, well, you want to produce something to deal with the rough edges of this patient, of these individuals, if they come to the clinic. You have to. So we did a study in the practices of 500 French psychiatrists on MDD and find out how many, this is American MDD, basic depressive disorder, how many of the MDDs actually had bipolar disorder, okay, in 4 major sites in France. Now, at first interview, these are all American instruments translated into French, okay?
Okay, you get the idea. Sanofi wanted to make more money. He's like, well, we need to invent this thing and convince a bunch of people in France that it's a thing, and that's what he did. So, and I read this big study. They made up criteria for this bipolar 2 and then show that folks with depression actually had bipolar 2, right? So hopefully Sanofi made some money off of that.
Paper, when I said something, think about it.
There we go.
And then we come to this. You're accepting this one.
I felt like this is important. It's just him admitting he published his own paper in his own journal because others wouldn't publish it. It just seems like science has gotten a little more rigorous maybe since the 80s.
Think about it. And then we come to this. You're accepting this one, right? Depressive mixed states. Correct? Correct? 3 papers rejected it. And I had to publish it in my journal in a special issue because I thought this is something very important. I saw these patients. I see them all the time. Now, as editor, you have the privilege once in a while to have something published that you're a co-author of. That's one of the few privileges. I've violated, I wouldn't say violated, but I've done this maybe 3 times in my 17 years tenure as editor.
Just in this talk, there's been about 6 papers or more that he published with his name on and in his own journal. So it's very much the thing that he's doing. I also just took some screenshots. I thought these were kind of funny. So our atypical depression, borderline personality disorder, and bipolar 2. These are from the talk, the grand rounds that I did. There's, go watch the whole hour and a half, maybe sped up. It's kind of hard to get through, but our atypical depression, borderline personality disorder, and bipolar 2 disorder overlapping manifestations of a common cyclothymic diathesis. The rule of 3, so hinting at soft bipolarity in clinically depressed individual. 3 or more depressive episodes, 3 or more failed antidepressant trials, 3 or more failed marriages, 3 or more failed distinct professions, or not failed, sorry, 3 or more distinct professions, 3 or more classes of substance abuse / alcohol, or 3 or more relatives with affective illness, and that's hinting at bipolarity for him. There's a paper, Is Migraine in Unipolar Depressed Patients a Bipolar Spectrum Trait? And then this is my favorite, Towards Identifying Bipolar Disorder Potential in Stem Cells. So, what did we know now? Well, let's start with a Cochrane review from 2022 titled Pharmacologic Interventions for People with Borderline Personality Disorder. They say, we found mostly very low certainty evidence that medication may result in no difference in any primary outcome. And the review supports the continued understanding that no pharmacological therapy seems effective in specifically treating borderline personality disorder pathology. Which is not to say that some symptom-focused reduction in suffering might be helpful, but overall, it's yeah, kind of throwing out one of his largest claims that he bases his conclusions on. So there's that. There have been very few randomized control trials examining the evidence for treatment of bipolar 2 depressions, kind of bipolar spectrum world. And the ones that have been done on medication were industry sponsored. So 2005, there was a clinical trial using quetiapine, an evidence-based treatment for bipolar 1 depression. They found no statistical significance in outcome for bipolar 2 patients. I think it was called the Boulder trial. And so they followed it up with Boulder 2. They found similar results. Then they had employees conduct a post hoc analysis of the bipolar 2 groups to show that barely a significant effect for bipolar 2 depression with quetiapine. However, the treatment group had a lot of side effects as expected. And this is the statement of interest on this paper. Mr. Rains and Dr. Paulson are employees of AstraZeneca. It's just, there's quite a lot. I mean, just basically employees. Looking at the recent clinical trial data that allowed for FDA approval of lumateperone, we only see that 20% of the study participants, or 38 people, were included in the treatment arm compared to 38 in the placebo arm with bipolar 2 disorder compared to 150 for bipolar 1. The study was only done over 6 weeks, industry sponsored. So 38 people. Yeah. So kind of pulling away from industry sponsored stuff, in 2018, there was a study completed comparing interpersonal and social rhythm therapy, or IPSRT, plus placebo, or IPSRT plus quetiapine, a maximum of 300 milligrams a day, and followed for 20 weeks and found no between group differences in response based on the Hamilton Depression Rating Scale. It's not sponsored by makers of the drug. They also found that with the quetiapine group, there was association of significantly higher BMI, dry mouth, and a trend towards oversedation, which one might expect. So coming back to Mark Zimmerman at Brown, he has continued to publish findings of overdiagnosis of bipolar disorder in his MIDAS study. His top paper, he concludes a wave of new effective therapies has been developed for the treatment of borderline personality disorder, and this is distinct from those that would be used to treat bipolar disorder, including DBT, CBT for BPD, mentalization-based, transference-focused, schema-focused. Misdiagnosis would presumably delay the use of these more appropriate psychotherapies. Furthermore, there's mixed evidence that medications used to treat bipolar disorder are effective for borderline personality disorder, with a Cochrane review of available randomized control trials concluding that pharmacological treatment of BPD in general is not based on good evidence. In his next paper, he concludes, we believe that the increased availability of medications to treat bipolar disorder and the accompanying marketing efforts are chiefly responsible for the increased false positive rates of bipolar diagnosis. He also adds, because clinicians are probably inclined to diagnose disorders that they feel more comfortable treating, we hypothesize that in many patients with mood instability who do not meet criteria for a hypomanic episode, physicians are nonetheless inclined to diagnose a potentially medication-responsive disorder, like BD, rather than a disorder such as borderline personality disorder that is less medication-responsive. And then in the bottom paper, this is the paper that I had in the beginning of the talk, but also wanted to circle back on some points he makes about direct-to-consumer advertising. He states the impact of marketing efforts and Publicity probably also plays a role. Direct-to-consumer advertisements that refer individuals to screening questionnaires can result in patients suggesting to their treaters that they have bipolar disorder. Screening questionnaires maximize sensitivity at a cost of false positives. And there's a lot that I had to cut out about the MDQ and studies that he did about that, but it's a little fraud. Another paper, so Philip Mitchell, an Australian psychiatrist and bipolar researcher, publishes extensive report saying the dramatic surge of public interest has led increasingly to patients not infrequently presenting with the request, "I want to be bipolar." He makes the point, concern that bipolar disorder was becoming overdiagnosed first arose more than a decade ago. Few others voiced public disquiet at that time, but the dissenting community began to gather strong momentum in 2006. In that year, David Healy wrote The Latest Mania, Selling Bipolar Disorder. His thesis was that the dramatic increase in professional interest in bipolar disorder, as indicated by rapid growth in publications, international societies, scientific journals, and conferences focused on this condition, reflected the growing pharmaceutical industry interest in mood stabilizing therapies, with the associated major investments in marketing and promotion of such products. He highlights the dramatic conflicts of interest between the spectrum disorder researchers and big pharma that has propagated a lot of this concept. And also explains how the research used to claim these ideas are based on non-specific validators and sort of illogical conclusions. Moving on, there's a lot in this paper, the bipolar spectrum, a bridge too far, but I will just include a snippet from Scott Patton's overall conclusion. He says, in summary, the rising popularity of the bipolar spectrum disorder concept appears to have occurred in the absence of any clear and accepted definition for what the term means, and in the absence of high-level evidence demonstrating its value in clinical practice. I picked some advertisements that were interesting. So looking at these, I just like you all to think to yourselves who you might imagine these marketing efforts are trying to reach, right? Are they trying to reach the severely mentally ill 1% or less of the population, or are they trying to reach a different population that's probably that is more prevalent, right? So find your own road, living with bipolar disorder, real expressions of bipolar depression, calypta, overwhelmed by the ups and downs of frequent mood swings. Vraylar can help balance your symptoms with one pill once a day. Sounds great, right? Yes. Finally, thank you, Dr. Hanslitz. Would like to finish with a tweet by Dr. Alan Francis, the previous chair of the DSM-4. He tweeted in December 2020, "I greatly regret adding bipolar 2 to the DSM-4. We had good reason to reduce iatrogenic switches / rapid cycling in spectrum patients due to antidepressants, but led to much iatrogenic harm caused by massive bipolar overdiagnosis and antipsychotic overuse pushed by pharma marketing." I also thought this, response, Dr. Tyler Black, seemed appropriate. He says, "Psychiatry pro tip. If you are suspicious but not certain your patient is manic, they almost certainly are not. The bleeding of mania leads to significant overmedication and inappropriate prescriptions of substances that, though helpful for actual bipolar disorder, have significant side effects." So in summary, and I feel like we're going to have a good amount of time for discussion. Bipolar disorder is an evolving concept that has swung like a pendulum between conservative and expansive diagnostic categories. Beyond bipolar 1 disorder, there's little evidence that medication treats mood swings, affective reactivity, chronic emptiness, patterns of interpersonal difficulties, or other symptoms of what we call personality disorder. Overdiagnosis leads to inappropriate prescribing of medications with potentially damaging side effects. There are evidence-based psychotherapeutic interventions to help patients with personality disorders, and we should advocate for appropriate treatment as clinicians. Also, questionable science and big pharma have propagated the idea of a vast bipolar spectrum in the absence of rigorous clinical data. Okay, I want to leave. We've got, 10, 11 minutes now for folks to chime in, share their thoughts. I'm very curious what people think about my topic.
Dr. Browning, the residents are all very excited about your grand rounds. I want to thank you for doing that. That was awesome. The thought that came to my mind was this concept of the manic defense and like how old this is. I think it goes back straight to Freud, and that we've just like, I don't know, in like reading about this, did you come across people like bringing that up again as like an explanation, a defense mechanism that probably should have be taught like formally versus just like whispered about in psychoanalytic communities? But it's like it's not one of the formal defense mechanisms we learn about in like medical school or like in classic defense mechanisms, and yet perhaps if it was, would explain all of these kind of presentations that, yeah, make us feel a little uncomfortable. Maybe this is some hypomania, but then it's kind of just like a defense mechanism, perhaps. And I'm just wondering what your thoughts are on that.
I absolutely, like, I think the kind of the long and the short of it is like Akiskal hated psychodynamic formulations for patients, and everything that we know now about, attachment and childhood trauma, like, adaptive behaviors for coping with, negative internal states and other things. Like, it's just, there's so much more to a patient than their mood swings, frankly. And I think there's such more useful ways to kind of think about our patients and conceptualize like what is the function of why they're acting a little hypomanic for 6 hours in a day, rather than being like, this is some kind of uncovered bipolar spectrum that is going to respond to lithium. It's not, also, what does that even mean, right? So yeah, I would love to see certain other topics kind of propagated throughout training programs in the country, and it's very variable where you go. I think some psychiatrists are still very much thinking about mood disorders and things like that. And then, oh good, Elison's here. There's
Hey.
hey. Speaking of everyone having a bipolar diagnosis, check out where we work. Yeah, no.
Yeah, no, well, don't get me wrong. Prison, a very common diagnosis in prison. But Landon, I just want to say I loved your presentation, and I don't it's gonna sound like I disagree, but I don't disagree.
Okay,
because
do it.
I think you're right on, and I think as a profession we need to be more accurate and really push for the appropriate treatments. Like, I think a lot of people would argue, yeah, but I can't get the therapy that my patients need. But we can't give up on it, and I think we need to be accurate. And if you want to medicate borderline personality like a bipolar, well, at least call it what it is and just justify your rationale.
Yeah.
My one little plug would be, don't swing too far the other way. And bipolar is a real thing.
Yeah.
It's not that patient who's sitting there calmly on your couch saying how manic they are, but it does exist. And we've all seen real mania.
Mm-hmm.
And when I was an early career psychiatrist, which I guess I'm not anymore, but I remember my first couple of years, I was pushing back on everybody's bipolar diagnosis.
Mm-hmm.
And if I hadn't seen you manic, I didn't buy it. And I remember I had this one patient who got out of the hospital and came to me and he's like, I'm not bipolar. We went through the criteria and he clearly didn't meet the criteria. And I was like, I don't know what the hospital's thinking. And so I took him off his antipsychotic. And then 2 weeks later, luckily the police busted down the door to his house and saved his family's lives, who he had taken hostage and was threatening to kill them. And that was just like an eye-opening kind of scary incident. And so I just want to, Landon is totally right. It is way overdiagnosed. And at the same time, don't swing too far. Yeah.
Right. And that is not to say, like we, the fourth years, we've been on Mailing, Harborview. We have seen the sickest of the sick Right, we know what mania is. Like someone's on 30 of Zyprexa, 4 milligrams of Klonopin, and they're still not sleeping, and they haven't slept for 7 days, and or a month, and they're running around the unit like verbally assaulting people and stuff, right? Like we know what that looks like. That is one end of the extreme. There's room there, right? But there's also, I think, when we think about how these concepts spread, they don't just spread through the psychiatry community or the psychiatrist community, right? Our therapy, our psychologists, licensed master social workers, counselors, all of these folks are listening to what we're saying, and then they are propagating these ideas as well through their communities. So it doesn't, and then I get patients coming to me saying that their therapist has diagnosed them with bipolar disorder and ADHD and autism, and they want me to start medications. And it's just like, no.
Yeah. Hey, Landon, this is Dr. Shackelford. I
Yeah.
just want to say awesome presentation. I thought that was both really entertaining to watch and a very important topic. And I just wanted to quickly add my perspective is having actually trained at UCSD where Dr. Akiskal was, and I had numerous lectures from him as well as Dr. Stahl. And that guy you had in the picture with the stem cells was actually in my class. So, and he's a good guy, MD, PhD, really good guy, very bright. But when you're in that environment, those figures are so influential, and you're so prone to being, believe everything they say. And it was very validating to watch your presentation because it took me a long time to come out of that environment and sort of face reality that the things I was doing with patients weren't really getting them to where I was happy with what I was doing and where they wanted to be. And I had to kind of go back and learn the whole psychodynamic side of medicine, because I really didn't get that training there because the biological emphasis was so heavy. And it brings up kind of sadness for me, actually, that because that was a very influential institution and person you're talking about, which is kind of what you're alluding to. The downstream effects of that are huge. So yes, don't go too far in either direction. Let's have a balanced approach and understand both the psychological and the kind of psychopharmacological side of our patients.
Yep. Wow.
Nice job. Yeah.
We have a question in the chat from Dr. Litchfield. I don't know, Dr. Litchfield, if you're still on, you want to ask?
Do you think you will use bipolar 2 diagnosis in your clinical practice? How should we make sense of the fact that the diagnosis remained in DSM-5 in light of Dr. Francis's remarks? If I were to use bipolar 2, it would be so similar to what I think of as bipolar 1. And it's so rare, I wonder if I'm gonna see it and I'm gonna think it's a thing. I'm not gonna be surprised if we see the pendulum continue to swing, and in the next iteration of the DSM, these ideas kind of consolidate and get more conservative. Hagop Akiskal died in 2022. And so we don't really have his voice kind of propagating a lot of that stuff in those communities anymore.
Three quick thoughts, Dr. Browning. Number one, this supports my theory that the free market can ruin anything it gets deeply involved in. Number two, one of the risks is the second somebody believes there's something biologically wrong with them, all of a sudden the sense of personal responsibility and taking personal action goes out the door. And number three, what the heck is this diagnosing a model by her skin in the picture?
I know. I was like, wait, what? Oh my God. It was so sexist and just gross. I was like, ew, this guy. Yeah. not only is it kind of garbage science, but it's like, where do you come from? Yeah. Oof. Anyway. Anything else that anyone would like to add?
I'll say that I think that it's so important that we understand like why we came up with like where these ideas of what an illness is came from, you know, like how the nosology evolved from one thing to another thing to another thing, and the influences, whether they be cultural or through the institutions of the of big pharma, or whether it's academic, and then we kind of can like trace ourselves that lineage and understand how what we're doing right now is really much more inherited than it is based in the modern science.
Thank you.
So I thought this presentation really did that, and I appreciate that. Thank you.
I think it also brought up the dangers of pathologizing a normal spectrum of behavior, which seems like, I feel like we spend so much time providing education that yes, you are a human being, you're going to feel irritable, you're going to feel overwhelmed by your emotions. And I really loved your presentation, and just thought, similar to Charlie, that the vultures will come out anytime there's money to be made. It seems like this happens a lot in our field, and it's really helpful to know, where did this idea come from, and what are the different ways we can fight against it.
Thank you.
I feel like one of the challenges that I'm starting to notice we face in our world, especially with all these folks diagnosed with bipolar incorrectly, is like how to help them. And like a lot of times they're very attached to their medications. And like
yeah, and there is good evidence, right? So I think the Eindhoven meta-analysis from 2010 about symptomatic treatment in patients with borderline personality disorder, there is very large effect sizes for anger and anxiety with mood stabilizers. So it makes sense that this guy treated patients with borderline personality disorder with mood stabilizers, and they had symptomatic improvement, right? And we see that in our meta-analyses even today. But like Dr. Elison is saying, right, it's like, let's be specific about the diagnosis, right? Like, let's learn how to give this diagnosis well. Treat symptomatically, right? Like, be like, yeah, these medications can be helpful for you, but be upfront about, based on the best of our knowledge, what it is and what we're treating.
Which is funny you say that, because the inverse is true in our comfort for diagnosing personality disorder. Like, yeah, we love, apparently, like you look at the epidemiology, we love throwing around bipolar, but we hate talking about borderline. We hate that. We don't want to, like, who's going to tell the patient they have borderline? Like, oh, I guess I'll do it, you know, or like, no, I don't want to do that. Their outpatient person can do that, or like, you just kind of don't touch it. And maybe that's like one of the things to push for, is like really comfortable talking about symptoms that are like clearly on the spectrum of personality, and like really talking about that openly, versus like, oh yeah, you're having depression and poor sleep because of these things. Like, you know, it's almost like, it's very stigmatizing, right? Like we talk about sleep hygiene and using a CPAP, and then it's like, ooh, but we're not going to talk about your unstable history of relationships and like your chronic suicidality, and like, you know, and I think we can find compassionate ways to tell that story to people based on like a psychodynamic and developmental approach, but we don't do that very often. It seems like as often as we could, perhaps. So.
All right. Thank you so much, Dr. Browning.
Thank you all. And I will see some of you shortly.